So today we're going to talk about optimal approach, BR or FCR or FR. And I guess my hope is that within a couple years this will be a moot question given what we've heard about kinase inhibitors already. But okay. Oops. So my answer to that is absolutely bendamustine rituximab has replaced FCR for frontline therapy of CLL. But that's a different question than the next one, which is, can I win this debate? And that's not so clear. It's a little more clear now that Dr. Keating isn't here. But so I had this nice series of slides here. I said, so can I win? Well,
It's our friends who hurt us the most.
Mm-hmm.
It's our friends who hurt us the most.
So I said, who's instrumental in developing FC and FCR? Well, that's Dr. Keating, definitely. Me, not so much. And, well, he gets to use 3 drugs, yep. Me, I only get to do 2 drugs. And, he's got this really professional demeanor, and I don't want to, say anything about Dr. Furman, but he and I, kind of not so much. And the cool accent, that's definitely something you're missing with Dr. Keating, and Dr. Furman and I, not so much. So, I'm definitely the underdog, or at least I was now. And so I'm saying root for the underdog, so when they ask you the question later, BR wins, right? Okay, because there we go. So what do we know about chemotherapy for CLL? So everything's better than chlorambucil. That's in terms of progression-free survival. Fludarabine, if you add cyclophosphamide, is better than fludarabine for progression-free survival. When you look for overall survival, none of this makes much of a difference. It really doesn't. Dr. Rai, if he was here, would show his data with fludarabine very long in the CLGB study, showed maybe a bit better survival than the chlorambucil arm, but years out. So survival-wise, which is really what we want to know, we haven't made a big impact. So when I think about what I want to do for upfront therapy, whether it's BR, FR, FCR, so we're balancing efficacy and toxicity. We want to know, can we use that in most of our patients, or is it only a select group? What's the quality of life of the patient? How many times they have to come? What supportive care? Do they need prophylactic antibiotics, et cetera, et cetera? What am I going to do second line? Am I burning any bridges? And with what you've already heard this morning, how are we going to combine these with the novel agents that are coming down the line? So we're going to ask all these, I'm going to talk about all these questions in terms of BR and FCR. So here's the data that we have. I've taken this from a really nice editorial that Bill Weirder wrote in JCO last year, and I've summarized some of the references and sort of pared it down. But so you have the MD Anderson FCR data, 300 patients, median age 57, high response rate, very high CR rate, and PFS. But when you put FCR in the real world, in the German CLLA trial, median age was a little higher, response rate's still high, but the CR rate's lower, PFS a little over 4.5 years. FR in the CLGB phase 2 trial, multi-center, but now phase 2, a little bit older, still high response rate, CR rate in the same range, PFS 3.5 years. And in the German BR phase 2, again, multi-center, but phase 2, median age 64, high response rates, CR rate maybe a little lower, PFS about 3 years. So if you look at that, you go, well, FCR may be a little bit better, but when you look in the real world, the difference isn't as much as when you look at the MD Anderson data. And age and performance status, do affect response rates. So it's really hard to compare these across studies. So it's pretty clear that if you get more intense therapy, you get deeper remissions. So you can get to the CR rate by classic NCI criteria. You can get another couple logs kill and get down to MRD negativity. And how long it takes to really get progression, your measure of progression-free survival depends on how deep your remission is, but also how fast the disease grows back and how hard you look for progression. And the question about BR is it more like the fludarabine, or is it in between fludarabine and FCR, or is it as good as FCR and FR? So I didn't know you were going to ask that question about prognosis, but it's pretty clear that patients with deeper remissions get longer progression-free survival. And that's not a big surprise. Responders do better than non-responders. Molecular responders do better than less deep molecular responses. And so, FCR was better than FC, and that's not a big surprise because R is always better than without R. So when you're thinking about chemoimmunotherapy, once you add rituximab doesn't add a lot in terms of toxicity. BR versus FR, not really clear the toxicity, but when you add FCR, when you add the C, clearly more toxic than BR, and I'll show you that. So what do we worry about in terms of toxicity? I'll talk a little bit about long-term toxicity later this afternoon, but so common concerns with chemotherapy is who can I treat? Am I going to get prolonged myelosuppression? And I'll talk more later about myeloid neoplasia and secondary cancers. Now with fludarabine, especially FCR, most of us don't like to treat older patients with this. It has significant prolonged immunosuppression. You have to worry about kidney function. And there's a sense out there about autoimmune hemolytic anemia, but the data are a little unclear. But certainly some patients where you get a flare of autoimmune hemolytic anemia. Bendamustine, yes, myelosuppressive, and there's this funny rash, maybe tied in with allopurinol. But other than that, it's a pretty easy drug to give. So who got treated? So these are the two German studies, the FCR and the FCR-FR study, and the German phase 2 bendamustine rituximab. So you look, the median age was only 3 years older, but half the patients in the BR study were over 65, which is the real world. Only less than a third were over 65 in the FCR trial. Performance status, you could go up to 2 in this BR study. Cumulative incidence score for comorbidities was limited, and the median was only 1 in the FCR, and you could have anything in the BR study. Creatinine clearance was limited in the FCR study, not so much in the BR study. And even with all these limitations about who they treated, they only got a median of about 5 cycles of FCR, where you could get all 6 of BR. And interestingly, a quarter of patients in each study did not get all 6 cycles. But when you look in blood counts and infection, FCR is clearly more toxic in terms of neutropenia and infection, although the BR data had more thrombocytopenia. So you can say, well, FCR is more toxic, but maybe it'll take care of the bad biology. And you look at 17p deletion, and we'll hear more about that from Dr. O'Brien a little bit later, but it really doesn't overcome FCR. FCR does not overcome 17p deletion. It may overcome 11q, so I may grant those guys the 11q data, but we'll see what we think about that. All right, now FCR, not only is it acutely toxic in terms of neutropenia and infection, but it's prolonged, and this is the MD Anderson data they published earlier this year, that they had 38% late infections after chemotherapy was over, and it took in a number of patients 3, 6, and even 9 months or longer to recover counts. So you really have prolonged cytopenias after treatment, which require monitoring and treatment and prophylaxis. Again, I'll talk more about this slide this afternoon, but in terms of therapy-related MDS and AML, FCR clearly higher than F alone. In the CLGB data, F and chlorambucil, so fludarabine and another alkylating agents, clearly higher risk than fludarabine or alkylator alone. BR data, we don't really have a lot of good long-term follow-up at this point, but one might think that it causes it, but it's not really clear. I do want to make an ad for this study, which we are eagerly awaiting the results for. This is a CLGB-run intergroup study, which looks at FR versus FCR, because I think that is still an open question, how much better adding the C is in terms of toxicity versus efficacy. That study's closed to accrual, so we're waiting for the results. All right, so let's talk about BR and FCR in terms of combining novel agents. We all want to use these new kinase inhibitors. BR and FCR are not considered curative, so we want to build on that. And BR is more accessible to more patients, and it's less myelosuppressive, so I think it's going to be easier to combine with these agents. And in fact, most of the studies you see now are BR plus a kinase, not FCR plus a kinase. So I think in terms of where we're building, that's also an important issue. So what are our goals in CLL? Well, we'd like to cure the patients, but we don't think we do that today. We'd like to prolong overall survival, and no chemotherapy has really been shown to do that as yet. We'd like to prolong PFS. Well, that's not really a great goal. We would like to achieve minimal residual disease status, yeah, as a marker of PFS, but again, is that just responders do better than non-responders, or does it really impact overall survival? We don't really know. So FCR clearly achieves MRD in a higher percentage of patients, but I'm not sure that's very useful. So in terms of the keys, cure and prolonging overall survival, we don't really have data. There is a CLL trial, BR versus FCR, but again, that's only patients with creatinine clearance over 70 and low comorbidity score, so it's not going to be applicable to all your patients. So I would say BR is equivalent response rate, trying to compare different studies, maybe a lower CR rate, but this was a higher risk population of patients. It's applicable to more CLL patients, wider age group, performance status, renal function, et cetera. It's less toxic, less myelosuppressive. We don't know yet about MDS, but if it's less myelosuppressive, may well be less MDS. It's certainly less immunosuppressive, fewer late infections. And it seems to be easier to give later treatments, and clearly easier to combine with some of the new agents. So how does BR stack up? As I look at this, it really wins on all these questions. So yes, maybe you don't get as high a CR rate or molecular CR rate, but everything else in terms of practical aspects, BR wins. So if you have a young, healthy marathon runner who has 11Q, then maybe you want to give that patient FCR. But for everybody else, I would say you should be giving your patients BR, and then worried about what to do down the line with these fancy tyrosine kinase inhibitors. So with that, I think I win.